Hello, friends, and welcome to my YouTube channel. And today we will discuss a very important topic, that is antifungal stewardship, both the approach for a diagnostic and a therapeutic one. I got the opportunity to present this in a sepsis international sepsis forum, and I thought I should upload this to my channel for the viewers. So, no conflict of interest. And we will start with one clinical scenario. A 50-year-old lady, non-diabetes, hypertensive, recently diagnosed acute myeloid leukemia, received induction chemotherapy, and after induction chemotherapy, she developed neutropenia. On day 6 of neutropenia, she developed fever and admitted to the hospital and eventually shifted to ICU with new onset hypotension. As per hospital protocol, she was started on piperacillin tazobactam, amikacin, and on voriconazole prophylaxis. In ICU, we started fluid resuscitation along with noradrenaline. In in case 1, the patient has hypoxic respiratory failure. He was started on HFNC and the chest X-ray, as I mentioned here, shown a right lower zone consolidation. And in case 2, the patient was having a sinus tachycardia, saturation was okay even in room air. Patient has a peak line peak for 16 days, and you can see the site of the puncture is not very healthy. So between these two, which patient need an antifungal escalation? And I think you will agree that the second patient, in the case 2, will need a antifungal profile escalation, because in case 1, the patient has a pneumonia with septic shock, and fungal pneumonia causing an acute onset septic shock is very unlikely. So this is the first step of antifungal stewardship, that we should implement our clinical knowledge, clinical understanding to decide whether this acute deterioration is because of fungal sepsis and whether we need an escalation in terms of antifungal medications, because the options of fungal medications are very, very limited. So when we talk about antimicrobial stewardship, it is implementation of a coordinated interventions to improve and track the appropriate use of antibiotics. It's not about de-escalation or giving a narrow spectrum. It is about appropriate. Sometimes an escalation of antibiotics or antimicrobials is also a part of stewardship. So use of appropriate antibiotics while offering the best possible antibiotic prescription in terms of drug, dose, duration, and route of administration. These are the 5 objectives laid down by WHO. Among them, the objective 4, that is optimize the usage of antimicrobial medication in human and animal health, is most important and applicable for the clinicians. And whenever we are optimizing any antibiotics or antimicrobials in intensive care, so basically two teams are in interaction. One is the primary or the admitting team and the ID microbiology team. The first team usually start the antibiotic, and their role is in terms of prescribing antibiotics when they are really needed, controlling the source of infection, and prescribing antibiotics in an appropriate dosage. And it has been reviewed by the microbiology and ID team as a part of stewardship protocol. Their role, along with enhanced infection control prevention, supporting an interdisciplinary approach, and educating staff, which are indirect interventions, along with supporting the surveillance of antimicrobial resistance and hospital-acquired infection, monitoring antibiotic consumption. There are some direct roles, like decrease the duration of antibiotic to the shortest possible one according to the evidence, reassessing the treatment and look at the culture and optimize antibiotics according to the cultures. So, the antibiotic stewardship is basically a fine balance between appropriate initial broad spectrum antibiotic, which are usually empiric, and an unnecessary antibiotics, and which will eventually lead to an increased cost and resistance. So, In terms of role of stewardship, there can be therapeutic stewardship. For that purpose, what we do, we usually, as I mentioned, 4 Ds like right drug, right dose, right dosing interval, and right duration. The initial antibiotics, initial antimicrobials can be modified by a prospective audit and intervention and feedback given by the ID micro team, or there can be a process of formulary restriction or pre-authorization where before prescribing a certain group of antibiotics, you need a clearance from your ID micro team. When possible, better to change from a parenteral to oral therapy when the oral absorption is predictable and acceptable. Along with that, we have to combine interventions from the diagnostic stewardship. Like there should be an appropriate usage and facility of microbiology lab in terms of different testing so that you can modify your initial prescription in a correct way and you can streamline or de-escalate your antimicrobials according to this laboratory results. So now if we look at the antifungal stewardship, there are some essential elements of it like creating a collaborative group, identify the need of an antimicrobial antifungal stewardship by pre-implementation implemented audit and identify the target. There should be an educational program to disseminate knowledge, implement local guidelines, daily and regular follow-up, implement rapid diagnostic tests to optimize and de-escalate your medications and bedside interventions. And we need to accept that effectiveness of the intervention should be measured using some predefined indicators. And when you're talking of a team, it have to combination of a multidisciplinary team, which should include an ID specialist, medical microbiologist, hospital pharmacist, along with an internist and infection control nurse. And there is a significant role of an intensivist to keep all these specialist people to keep them on the same platform with a defined target. But implementing an antifungal stewardship is not easy. There are a lot of clinical dilemma while choosing the drug. Like in the early phase, fungal infections can be asymptomatic or there can be non-specific symptoms like fever and cough. Microbiological cultures by conventional technique has very low sensitivity. Getting an invasive diagnostic procedure done is challenging because these patients can be really sick with neutropenia, thrombocytopenia, hemodynamical instability. Radiological features are non-specific. Serological tests are not easily available and not confirmatory. And PCR-based tests are still developing. They're at their infancy and still not been has been standardized to take medical decision or clinical decision. But even with this, we need to accept the diagnostic stewardship with the best possible available way so that we can optimize our medication in our patients. So just to look at the classification of fungus, it can be an yeast. Among the most common is candida or can be mold. Mold can be accepted where the most common organism is zygomycetes like rhizopus and mucor and it can be septate and among that group most common is the aspergillus. There are other fungus also, but of secondary importance. And whenever we are prescribing antifungal therapy, usually the target or intent can be one of these four. It can be prophylactic, it can be empiric, it can be preemptive, or it can be targeted. When you are talking about prophylaxis, that means no infection is there, we're giving antifungal because the risk of fungal infection is very high. You want to prevent it, but decrease the incidence. Empirical means there are clinical scenario. We are giving antifungal, suspecting this patient has a fungal infection. Preemptive means along with empirical risk factors, there are clinical features. There are other non-culture based evidence. It can be radiology, it can be serology, it can be biomarkers. And targeted means there is a proven infection when there is a culture based positive report from a sterile site or from a tissue. So if you look at the prophylaxis, as I mentioned, it is effective only in high-risk patients. It has shown to reduce the incidence of invasive candidiasis in this group of patients. No positive impact of mortality has been shown except in severe immunocompromised patients like prolonged neutropenia, bone marrow or solid organ transplant patients. So the role of antifungal prophylaxis in medical surgical ICU is pretty doubtful and we should not practice it. What about empirical therapy? So whenever we are considering an empirical therapy that I'm suspecting fungal infection in my patient, we have to answer these three questions. Is fungal sepsis a genuine concern in my patients? Is my patient is high risk for developing a fungal infection? So what are the host factors, which is very important for fungal infection evaluation? And is there a harm if I delay the treatment? So we have to be aware about the epidemiology of my country and also of my hospital. Most of the multi-center studies in India has been done under the guidance of Dr. Arunalok Chakravarti from PGI Chandigarh. This is one of those multi-center paper which called SIHAM Candidate Anemia Network. When it has been looked uh, for multiple centers about the incidence, characteristics, and outcome of ICU-acute candidemia in India. What they found an incidence is around 6.5% per thousand admission. Median ICU days is 8. That means some of the patients develop early candida infection in the ICU. Apache 2 score is 17. That means all these patients are not that sick. We have to have a lower threshold to suspect fungal infection. 31 candida species has been identified during this journey. And the most common is tropicalis followed by albicans compared to the conventional belief. And the mortality, if you look, 30-day crude and attributable mortality is 44% and 19%. Among all these centers from Calcutta, CMRI and Apollo Clinicals Hospital has also contributed data. So we can be accepted in terms of the epidemiological data of Calcutta also. Similar data has also been obtained from Sentry trial when it has shown that the most common species for in bloodstream infection for Candida is albicans along with tropicalis and parapsilosis. What about aspergillus? We know that aspergillus can be a problem specifically in certain subgroup of patients like hemato-oncology. But when you look at the overall data from a general hospital, they found nearly 398 cases of invasive fungal infection, both proven and probable. Incidence is around 10%, Aspergillus being the most common bug, around 82%, followed by Mucorales and Fusarium. And the mortality, as we can anticipate, is significantly high, as high as 60%. 60% in case of 42-day mortality and 84-day mortality is around 65%. What about an immunocompromised host? In immunocompromised host, the risk of fungal infection is higher, but the epidemiological distribution is remains same. Like Candida comprises 70 to 90%, followed by Aspergillus of 10 to 20%. And the risk of mold infection increases with the severity of immunosuppression. Like Candida is more common in medical ICUs and surgical ICU and after solid organ transplant. On the other hand, Aspergillus is more common after a hematological malignancy or post chemotherapy and also in case of bone marrow transplant. So, what are the risk factors for Candida? We are aware about the conventional risk factors like prolonged ICU stay, prolonged sickness, corticosteroid, diabetes, age, extremes of age, invasive catheters. Along with that, intragastrointestinal surgery or stomatic leak, parenteral nutrition, prolonged antibiotic usage, acute necrotizing pancreatitis. We can see the concerns are related to gut and abdomen. Along with that, some complications or risks related to oncology like chemotherapy, immunosuppression, solid organ tumor, solid organ transplant, high severity disease severity with Apache more than 20, hematological malignancy, neutropenia, specifically prolonged neutropenia more than 7 days, malnourished patient, malnutrition, and patient is on renal failure and requiring hemodialysis. Along with that, if the patient is colonized with candida at multiple sites, risk increases significantly, along with a burn or after major trauma. For invasive aspergillus, invasive aspergillus has been reported from multiple Indian ICUs, and gradually we identify the environmental factors like the spore count. High spore count in ICU can be a really high risk factor, along with a lot of non-classical risk factors has been evaluated and have evolved, along with hemato-oncological malignancy like COPD, bad COPD, uncontrolled non-diabetes, CLD, CKD, and after viral pneumonia like influenza, and it has been well established after COVID. So we have to have very high suspicion in this group of non-classical risk factor patients. Similarly, along with aspergillus, the mucor is also a big concern in India, and it has been shown from different models that the mucor load in India is significantly higher compared to the rest of the world, as we can see. And that is mainly because we are a diabetic hub. The number of diabetic patients in India is very, very high. And a lot of times mucor present as a diabetic presenting syndromes with a very high attributable mortality per year, more around 30 to 40%. What about it late diagnosis? What if I wait and not start my therapy empirically in this group? It has been shown in multiple studies that it increases mortality with delayed initiation of antifungal therapy, specifically in case of candidemia or bloodstream infection. In Gary's study, it has been shown that every day delay in antifungal therapy increases mortality. In case of Morel study, they took it as a 12-hour cutoff and found that there's increased mortality. And when you compare the first appropriate antifungal dosage from the positive blood culture, they found that after 15 hours of delay, the mortality increases significantly with a positive blood culture. And it is more applicable, shown in a meta-analysis, that it is more applicable if the patient is in shock. So it can be concluded easily that delay in initiation of antifungal therapy following in hypotension is a big factor in decision of in terms of the outcome, and the mortality increases significantly. Scoring system for Candida, there are different scoring systems like colonization index, Candida score, and predictive rule. For colonization index, we need the number of the colonized site divided by the number of site tested. Now, when we incorporate the load of Candida colonization, so it can be modified into corrected colonization index, and which include the number of sites with a heavy colonization among the number of positive sites. And the cutoffs are different. For colonization index is more than 0.5, or corrected colonization index is more than 0.4. Next is the Candida score, where they try to evaluate the risk of fungal infection or Candida infection in ICU, medical surgical ICU patients. Here the cutoff is 2.5 with the risk factors like multifocal Candida colonization species, GI surgery, and ICU admission, sepsis, parenteral nutrition. And they have seen that it has a very high sensitivity, but specificity is not that high. And the risk of false positive report is very, very high. So next is clinical prediction score. Here they look at systemic antibiotic, presence of central line, along with total parenteral nutrition, major surgery, pancreatitis, use of steroid and immunosuppressive therapy. They found this scoring system may not be that sensitive, but it's a very, very specific, with a specificity nearly 90% and negative predictive value nearly 97%. So it may really help us for ruling out of any invasive candidiasis. There are other scoring systems like Ostrowski-Gisner score, more applicable for intra-abdominal sepsis and pancreatitis. And we know the empirical treatment for a candida infection in a sick patient is echinocandin, according to all the international guidelines, specifically if the patient is in septic shock. And why? Because the epidemiological data has shown there can be a significant resistance to fluconazole for tropicalis and sometimes with albicans also. But as we can mention in Indian scenario, tropicalis is much more common compared to albicans. In a sick patient, especially the patient is in organ failure and shock, it is better to start with an echinocandin and later de-escalate depending on the culture sensitivity to a azole. This is the scoring system for aspergillus pneumonia. EORCT MSG criteria we are all aware, which include host factor, clinical criteria, and microbiological criteria. If all three criteria are present, it's a probable, two criteria are possible, and if there is a positive mycology or histopathology from a sterile sample or from a tissue, it's a proven fungal infection, aspergillus infection. But there are other scoring systems like ASP-ICU, which is more applicable for a general medical surgical ICU. And once we incorporate biomarkers into it, It is called BMS by SU criteria, and depending on that, we can divide these patients into probable, possible, or colonizer. So by this incorporation of these biomarkers into our scoring system, we are moving towards something called preemptive therapy, called empirical therapy. So if you look at the biomarkers, specifically for Candida, we all are aware that Mannan or anti-Mannan antigen, beta-D-glucan, and there are different PCR-based tests like Septifast PCR or in-house PCR. Now, PCR tests are still not very strongly recommended unless they are standardized. And along with that, if the patient has invasive candidiasis, we should try to get a sample from the deeper tissue by and look for direct microscopy, histopathology, and culture. What about aspergillus? Biomarkers which are acceptable are galactomannan, both in blood and respiratory sample, preferably BAL, beta-glucan, which is a general marker for Candida and Aspergillus, which is we need to remember beta-glucan will be negative in case of mucor, and Aspergillus PCR. Radiology can be really helpful, specifically in case of Aspergillus pneumonia. There can be halo signs, air crescent sign, nodules, ground glassing in these patients, which are strongly suggestive of a fungal infection in appropriate clinical context. So when you compare about empirical and preemptive therapy, if we have the support of biomarker and radiology, studies have shown that preemptive therapy can be a good alternative for empirical therapy in terms of antifungal stewardship. It can decrease the empirical usage of fungal antifungals in clinical practice. And as I mentioned, beta-D-glucan can be play an important role. It has a low pretext probability. It has a very high sensitivity. False positivity rate is high, but the negative predictive value is very, very high, more than 95%. So if it is negative, you can confidently stop your antifungal therapy. And you can and two randomized control style, it has combined beta-D-glucan with Mannan antigen and anti-Mannan antibody and used it as a diagnostic tool. Similarly, galactomannan can be used for aspergillus. It has a good sensitivity and specificity for both serum and BAL, more for a BAL with a higher cutoff. How about de-escalation? Now, yes, we already discussed that if the beta-glucan is negative, there can be a strong uh, justification to de-escalate your antifungal. And studies have shown that in a beta-glucan negative patients, the chances of positive fungal culture is very, very less. And if the patient has a fungal infection, you're giving an empirical antifungal, you can de-escalate as per sensitivity, like if the patient is stable, no shock, no organ failure, and if it's an albicans sensitive to azole, better to de-escalate from echinocandin to an fluconazole. And it is suggestive to do that after 5 to 7 days of initial echinocandin therapy in the critical condition. And you can stop antifungal in case of after 14 days of negative blood culture in case of candida. But how we react? Clinicians are very, very reluctant to de-escalate the antifungal. It has been shown that in a significant number of populations, even when the patient is stable and the culture sensitivity is showing the bug is sensitive to fluconazole, two-thirds of the clinicians are very, very reluctant to de-escalate to a narrow spectrum antifungal. And that is a problem in terms of stewardship practice. This we need to change both in terms of practice and also in terms of our mindset. And when we should not treat, like candida and sputum, candida and bile or urine, these are all colonizer. We should not treat them. We should take it as a site of colonization. Candida in old catheter of pleural fluid and ascitic fluid. So there may be old pigtail, old abdominal catheter, old chest tube. If they're growing candida in the later part of their stay, let's consider as a colonizer. But if we identify candida in the first puncture for ascitic fluid, we may need to treat it. So to summarize, we need to have a separate emphasis for antifungal stewardship, specific for units who are using a lot of antifungal. We need to restrict antifungal prophylaxis in only hemato-oncology patients with a high-risk patients and transplant patients. Empirical treatment should be based on the risk factor and the diagnostic-driven approach. Antifungal based on local epidemiology, CDL and PKPD advantage need to be remembered whenever we are choosing the drugs, and 4 Ds need to be applied. We have to achieve adequate source control, specifically for a candida and mucor. In mucor, this patient needs an aggressive debridement to have a better outcome. Stop early if you feel that we have started inappropriately, or de-escalate to a narrow spectrum drug once the patient is stable. For azoles, therapeutic drug monitoring is strongly recommended, and we need a regular auditing on antifungal usage, toxicity, and antifungal resistance to have a better outcome and to cut down the overall antifungal load in a clinical unit. By this, I'd like to conclude my presentation. Happy. Thank you.